Have something at yeah, 2 to 3, right? I will do it from home.
Okay.
Thank you, Chris. So do you think we can start or yeah?
It's okay.
Yeah, we are good. So we are going to talk about neonatal abstinence syndrome and the eat, sleep, console approach. Our objectives for today is to overview the opioid crisis in Canada, the new definitions of NAS and the different care models, to understand the journey that our institution experienced with the rooming model of care, understand the use that of the numeric scoring system that could be detrimental for the optimal management of NAS, understand the evidence to support the eat-sleep console approach, and our guideline development and strategies to successfully implement an eat-sleep console care in our center. And please stop me if you have any questions or if you want to add any new information that I don't have in this presentation, please. So a bit of background, since early 2000, Canada had experienced a surge in opioid use and death, opioid-related complications. The reason for the opioid use was the liberal prescription of opioids for pain management, the recreational use, the harm reduction methadone use that we will talk about that, and the polydrug use. You know, I need to move this because I cannot see my and this public health crisis had led to an increased number of overdose data and death since the surveillance began in 2016. If we count since they started counting this death by overdose since 2016 until September 2022, we almost had 35,000 deaths. The majority of them were reported in BC, Alberta, and Ontario. And we are going to see a big increase in this past report that is from January to September 2022. We had almost more than 5,000 deaths by overdose. Unfortunately, Manitoba didn't send a report from January to September 2022, but we can see that in the past 2 years there was steep increase in overdose and death related. So this opioid use disorder now impacted women, young women, and childbearing age. In the US, they said that moms that are admitted to the hospital to give birth and were exposed to opioids, this amount or this number of cases increased 134% from 2010 to 2017. This is in US. And we know that if we we leave this untreated opioid addiction, that can increase bad outcomes in mom and baby, like lack of prenatal care, fetal growth restriction, placental abruption, fetal death, preterm delivery, and increase the incidence of meconium stained amniotic fluid. So the use of opioids agonists during pregnancy, plus comprehensive addiction counseling and psychosocial service are necessary to support pregnant women and improve outcomes. This opioid agonist pharmacotherapy that we know now as methadone and buprenorphine were introduced and started in 1950s. And they are the first line of treatment, as we were discussing, to try to optimize outcomes in moms and babies. The ACOG strongly recommend medical supervised withdrawal during pregnancy because the very high risk of death and high risk of relapse. So methadone and buprenorphine help to suppress drug craving, withdrawal symptoms, and fetal distress, and is a key role in trying to prevent some complications associated with opioid misuse and relapse in pregnancy. For example, avoiding the risk of overdose with subsequent respiratory depression and cardiovascular collapse, and decrease infection risk of intravenous drug use. So what are the definitions? Because this opioid crisis is increasing, it was introduced a new definition on top of NAS, as we usually use, and is NOS. That is, are clinical features specifically for withdrawal from opioids. NAS, we continue defining all the spectrum of the medications, like any newborn exposed to one or more substances during pregnancies that start having withdrawal symptoms postnatally with this substance source are interrupted. Any withdrawal from SSRIs or SNRIs are defined as a poor neonatal adaptation syndrome. So there is an overlapping of the signs and symptoms between NAS and NOS, but the other components are respiratory distress and pulmonary hypertension. So you are going to see that in this presentation, I will use sometimes NAS and NOS at the same time, because the most important numbers that we started to see is opioid withdrawal now. So the signs and symptoms, so this is a serious multisystemic disease, no? That is associated with abnormal neurobehavior, autonomic nervous system dysregulation, respiratory distress, and gastrointestinal dysfunction. So how the babies are presenting to us, we can summarize and keep the first three on top of your mind, no? Feeding, poor or uncoordinated suck, poor sleep or increased irritability, and poor consolability with excessive and irritable cry. Some other presentations will be seizures, vomiting, diarrhea, and fever. Good. The severity of the symptoms depends on the type and dose of the maternal opioid, and is highly dependent on the half-life of the substance use. So we know that methadone and buprenorphine had a very long half-life that result in later onset of the withdrawal, usually after 48 to 72 hours, but these babies need to be observed for 5 to 7 days. And the other medications like fentanyl or heroin has a shorter half-life. So we usually see that these babies start experience symptoms during or after the first 24 hours of birth. The breastfeeding decreased the need of pharmacologic treatment and duration, you know, because transfer part of the opioids and avoid big symptoms on the baby. The combination with other drugs can precipitate or be the symptoms sooner, like SSRIs and mostly benzodiazepines if mom is there. And we don't see a lot of withdrawal in preterm babies, and that is why we have very low risk due to immaturity of the CNS and lower fat stores for of the drugs. So the prevalence of nose increased very, very rapidly. In a report that came out in April 2023, they said that every 18 minutes in the US, NAS is diagnosed in at least one baby as a result of an in utero exposure. The CDC and prevention in 2021 mentioned 8 newborns a day in the USA are diagnosed with neonatal abstinence syndrome or NOS. So what happened in Canada? So the last thing that I found published was this report that came out on 2018 that checked the numbers of NAS babies that utilized hospital, or moms were admitted for delivery and were exposed, so babies were admitted to NICU for withdrawal since the beginning of 2000, and we can see a very high incidence that tripled in Canada. This report excludes Quebec. I don't know why, but they didn't report it. And Manitoba had a 5-fold increase in this report of NAS babies. Hospitalization for NAS, as you can see, from 3.5 at the beginning of the report per 1,000 live birth to almost 6.3. And 71% of all these babies were admitted to NICU, and the length of stay was 15 days. So very creepy. So the traditional model and the things that we were doing before is to care for these babies in NICU. So we separated mom and babies were automatic admission to NICU. So the staff care for the baby. And in a Canadian survey published in 2014, 89% of the babies were in NICU. But NICU is not the ideal place to take care for these babies that had difficulties with state regulation, and they are very sensitive to noise, bright lights, and a very stimulated place. And the other care model that was used in some units that we are going to talk about was only separating babies or keeping the baby mom and babies together, and when the babies start developing symptoms, we transfer for therapy to start medications. So it started being a big push to try to care of these babies a bit better. No, try recognizing that this is a neurobehavioral functioning of the baby that needs to adjust, that mom, if she's involved, can take care of these comforting measurements, and rooming will be the most important thing that we can do, keeping mom together and mom taking care of all these signs that the baby has to try to avoid or delay the withdrawal. So the WHO recommended that the standard of care of any newborn is rooming. The AAP reinforced in 2020 that keeping moms and babies together facilitate bonding, breastfeeding, and rooming is the considered model, including in the NICU for babies exposed to opioids. CPS reinforced in 2018, again, keeping moms and baby together when the baby is withdrawing, doing rooming in will be the best care for the NAS baby. So this came out from in 2001, BC Women's Hospital started implementing rooming in all babies that were exposed to substances in utero, and they kept the babies in the postnatal ward. The initial reports in 2007 by Abrahams said that there is a significant decrease in the need for treatment of these babies, shorter the length of stay, and most likely the babies are going to be discharged 2 months. More recently, this is in February 2018, again, the same group from BC mentioned that rooming is the preferred care model for all opioid-exposed newborn, including when they are actively withdrawing. So, what happened in Manitoba when all these things in BC starting to change? So Lisa Merrill, that currently is the manager of Women's Health, started working and doing all connections to try to see if we can keep these moms and babies together for at least 7 days, no? Before immediate admission to an ICU. So she checked what happened after, during the implementation, and after, no? So she started counting the babies that were born in 2009 to 2012. All babies had straight admission to IMCN or NICU Notre Dame. And these babies were 44 in that period. 92% of these babies received treatment, so 40 of them, and the length of stay was very wide, no? From 2 days to 48 days. So in 2014 to 15, there was this pilot trying to keep the babies for at least 7 days in the postpartum area. So babies are going to be transferred only if they needed medical treatment. And 41% of them were discharged home without any admission, and the length of started was 17 days. At the same time, in 2015, we started, I started being involved, I was the medical director of IMCN at that time. So we started working on the NAS guideline. We didn't have any NAS guidelines before. The only guideline that we had, they said, immediate admission, or it was part of the attendance to high-risk delivery. So babies exposed, admission to an ICU, but no formal guideline. So we developed an escalation and weaning protocol of the medications, and we established that if any baby exposed of opioids, morphine must be the first line of treatment.
Sorry, just one question. The average length of stay is 17 days for those who are admitted to the ICU?
Yes,
those...
only, yeah. The other ones, they were 7 days, and mostly they went home, and only an ICU. So why we started working in the guidelines and this escalation and weaning protocols? Because that improved outcomes. So decrease length of stay and facilitate the safe weaning of the medications. So we were very happy with the guideline, but no one read. So we have no compliance. For example, in the first year, I think was 77% of the babies received phenobarbital. That was the old drug, drug that we use for withdrawal. So the quality team was involved, and at that point, Dr. Chu was the leader there. So they helped us to develop algorithms that we place everywhere. We did posters and laminated in each binders, in each baby's chart, and we they did a lot of nursing, did a lot of education about that. So what happened with all this information, and because we want to do a big change now, so where we are with all of these things that we did early 2010. So we, at the same time that we were working on Eat, Sleep, Console, we asked to have an idea of how many babies we have with NAS and how they are staying in our hospital. And we have very good support, and the data was retrieved, and we checked for in HSC and St. Boniface for any baby that at some point during the admission had a Finnegan score done or went home with a diagnosis of NAS. So these are all the characteristics and all the things that we wanted to know. So these are the number of babies that we recognize since 2018, that or at some point they have a Finnegan score done, or they were diagnosed with NAS. And you can see that it's almost the same numbers. More babies did have the Finnegan scoring, but they were not diagnosed. So maybe when, I assume, I don't know, I am speculating, maybe they went home without having any big withdrawal symptom that needed treatment. So we have 123 babies that had this Finnegan scoring done, and 304 babies that were diagnosed with NAS between 2018 and early 2022. So the areas where these babies came, or moms were managed, they were mostly WRHA, and a couple of places that were mostly the northern communities. The length of stay of the babies that were admitted mostly to NICU, that is the 73% of the cases, as you can see, is almost similar, no, to the pilot that we did that year, and it's around between 16, 18 days in NICU. How long the babies stay in MBU? So mostly following our recommendation, no? To keep the babies around 7 days to see for signs of NAS. So that is very good to know. And the combination between MBU and NICU. And here the thing that we can see is that the babies that need NICU, they started having symptoms very early, no? Because they only extend between 2 and 4 days in MBU before transferring to us. And again, the length of stay in NICU is almost the same, no? Less than 20 days in most of them. That's very, very good. And cost. So as we know, look, the days in NICU, what expensive it is, and look, the MBU.
And worth every penny.
I know. But if we can keep the babies there, will be great. And regarding breastfeeding, so we wanted to see in all babies, all birth, how the babies were discharged, no? And we have 42% of exclusive breastfeeding, 39%, this is all babies, no? Normal babies, 39% that have both formula and breastfeeding, and 18 exclusive formula. And our poor NAS baby had only 4% exclusive breastfeeding, 40% only, the combination between breastfeeding and formula, and 54% formula. So I think we can work on that. So The other important piece that it was recognized with time is that the Finnegan scoring that was developed in 1975 is the most used, but maybe we need to retire it. In a Canadian survey on 2014, 90% of our units using the Finnegan scoring. So as you can see, it's super boring, super long, 21 common neonatal symptoms we draw, and is only based on observed severity. Dr. Grossman, that is the one that pushed all the movement of Eat, Sleep, Console in BC, in one of his papers, he mentioned that the Finnegan scoring is not validated. The limit of the scoring is not validated here. Either, so why they choose the 8 to say that the babies more than 8 need treatment? And this was for a quote that in 1975, Dr. Finnegan put an observation. Oh, babies with the core 7, if we swaddle and feed demand, they are doing okay. But we observe that babies with more than or 8 or more in the score, those babies need treatment. So all our practice is based in this quote. And Dr. Grossman mentioned that the Finnegan scoring overlap with normal infant behavior. The nasal stuffiness and sneezes doesn't warrant opioid treatment. The Finnegan score does not promote the use of not pharmacologic measures. Scoring is often done in the moment, doesn't count for any other drug exposures. The goal of treatment is to decrease the score. And the families, they are not the center of the care of these babies. Other limitations that we found reviewing the literature is very intimidating in length and complexity. It's super long. You need a lot of treatment to try to minimize subjectivity. The assessment of some criteria require the baby to be disturbed, and that can increase the scoring. Is not validated in preterm babies, and is leading to more use of more medication. No? So in 2008, a quality improvement initiative in Yale New Haven Children's Hospital in Connecticut, USA, wanted to do an improvement in inpatient outcomes of babies with NAS. They base everything in the work that was done in BC, that remark keeping the babies together in the postpartum unit and only assessing weight gain and how the baby eats, how the baby sleeps. And the idea for them is to try to decrease by 50% the length of stay and the medications that the baby receives. So they were the ones that created the tool, and BC, they were okay to share with BC, no? That was the original change. So the Eat, Sleep, Console tool is a guide and support the care of these babies exposed and to try to achieve a normal eating, sleeping, consoling, and weight gain milestone. Is in the remark the importance of the parents as the primary care provider and support the inclusion of the parent as a member of the care team. And there is a philosophy of mom as treatment, not only to benefit the baby while it's in the hospital, but give the tools, the confidence and self-esteem so she can support the baby when they are going home. So we know that moms, when families, when they have a baby with NAS, they feel guilty, they have fears, they are very stressed, they express the need for increased support. They have some concerns about breastfeeding. In this paper that was published in 2021, one mom, because they have quotes of the families, and one mom said, I don't want to breastfeed the baby because I am giving more methadone, and the baby is going to be harmful. So a lot of education and a lot of talking to the families and improving communication can break that concept, no? And most of them, they look for empathy from the staff. One of the quotes is, don't judge, no? Don't be that person that say how you could have this baby in this situation, what you did to this baby, no? And this same study check for after implementing Eat Sleep Console, what the family think about. Do you want me to minimize this so you can read it? Yeah,
okay.
sorry. So one mom said they didn't really check on her as much as my son. They came in a lot and did the assessment with him a lot more than they did with her. They didn't like he didn't like any of that. It was a lot for him. So this mom is comparing Finnegan scoring with Eat Sleep Console. The doctors wanted to focus on his sleep, his eating, if he was pooping and being normal. I guess they just wanted him to be doing stuff that normal babies are doing. I was actually expecting to be here for a week and a half, but we actually weren't there as long as I thought we were going to be. And one mom mentioned, I think it's really good that you guys only detox him of the methadone instead of doing the morphine and the other medications. So all the things that we are seeing as a medical staff taking care of these babies with the Eat Sleep Console tool, families are expressing the same things, no? So the evidence-based care is aligns with family-centered care, baby-friendly initiative, trauma-informed, cultural safe care, and newborn responsive care. Allows for easy adoption and implementation and across all care settings, is an objective assessment with high inter-rater reliability, promotes standardized documentation and care, and is low cost, simple, and achievable. So the same as you, Rebecca, I didn't want to put the hits in PubMed, but I put a summary of all the. So the outcomes in all the papers are decreased opioid exposure, decrease the length of the stay, decrease in ICU admission, decreased cost of stay, and enhanced exclusive breastfeeding rates. More recently, I put two new papers in 2018. The same group, no, from BC, and compared 50 babies that were using the Finnegan Q2 to 6 hours, but they managed the baby with the Eat Sleep Console approach. So, and they found, 12% use of morphine in the babies in the group of ESC, and length of stay 6 days, and the babies that they stuck to the Finnegan scoring 62% received morphine, and the length of stay was 23. So very, very impressive. And the other one, not only Canadian, this is in US, so where 26 US hospitals, more than 1,000 baby was a cluster RCT. So they did the usual care, then they did the teaching, and then they checked the babies after implementing the sleep console. So the days, they check for days until discharge. The babies enrolled in Eat Sleep Console, they were in the hospital for 8 days, and the usual care almost 15 days, and decrease the number of babies or treated with medication, 32.5% points from 19 to versus 52%. So the evidence is here. So the approach is only to focus, as we discussed before, in only 3 observations. If all of these criteria are met, we don't need to do any intervention. If some of these 3 that we will discuss after are not reachable for the baby, Eat, Sleep, and Console, we are moving to our first line of treatment, that is optimize or increase the no pharmacological intervention, and involve usually a team huddle. So we are going, and remember, the parents are part of that team, to see if we have room to optimize a bit more the care of this baby and try to avoid treatment, or if the baby needs at that point start pharmacologic treatment. So this is in summary in the sleep console. So we need to reach, we need to ask mom how the baby is eating, how is breastfeeding, can take a bottle for more or equal to 1 ounce or 10 mLs. Can the baby sleep for more than 1 hour? And if the baby is crying a lot, with all the things that you are doing, can the baby stop crying in 10 minutes? So these are the essence of Eat Sleep Console. So, and this is the documentation that we are going very soon to replace EPR and the Finnegan, the old Finnegan, and we will put there. And as you can see, I will show you that the documentation of, or the scoring is only this, from here to here. Yeah, this one is the only thing. The rest of the page is only who is providing the care of the baby, what are the non-pharmacologic approaches that the baby is getting, if we need to do a team huddle, if we need to optimize the non-pharmacologic approach. So only that initial part is the scoring. Yeah. And on the back, you have all the definitions. What does it mean if the baby loses more than 10% of the weight? Okay, we need to do a team huddle and assess if the baby needs hypercaloric formula or whatever intervention we want. Or what do you mean that the baby cannot console for during at 10 minutes, and what are we going to do after? So this will be on the back of the page. Or if we need to start treatment, no? That will be the other thing. So this is a long list of all the things that we can do to the baby before jumping to treatment. So keeping the lights down, noise, controlling the noise during a lot of skin to skin, breastfeeding as demand, establishing some position, because the most important part that is very bad to reach is the console. And they put in the perinatal service visit that we can share this because they are okay for us to use all the educational package. They have very good brochures and pictures that are telling us, okay, how can we educate families not to take care of these babies and try to avoid medications. So we want to do it sleep console in Manitoba, but where are we going to start? So we just started. And I was super stressed because I didn't know from where. But I had an amazing group of people that helped me to go through a couple of steps. So the first thing, we invited Dr. Grossman to do pediatric rounds that were done, I think was at the beginning of 2022 or the end of 2021. Then we have our initial multidisciplinary meeting in May 19, 2022, so almost 1 year ago. So we, that meeting was brainstorming and the same question, where are we going to start with this? We started involving people. Okay, we need to involve rural areas. We need to involve all the nurses educators, representative from all the two hospitals, because the logistic will be a bit different between St. B and HSC. What else? We invite obstetrics. Dr. Watson was part of the group, social workers, so everybody. So we decided to create two subgroups. One that was going to work in the guideline and the other one in education. But before starting with education, we need to have the guideline completely approved. So in August 2022, Dr. Watson, Veronica, that was covering for Chloe, that was on maternity leave from St. B, and Kira Friesen from HSC. So we met virtually and we started working, developing this guideline. So we use our old guideline and we build up from that. At the same time, the following month, I connected with Christiana from HSC and Teresa from St. B pharmacies to try to work in the escalation and winning protocol, because Sleep Console, as we are going to discuss very soon, has breakthrough or PRN morphine doses. So we needed to change our approach of this loading dose and start maintenance right away. So we needed to see if that is going to be okay for us to use it. So we hope that the guideline is finalized now, and Kira and Chloe are voicing this guideline everywhere for approval. And we connected with the experience of other centers in Canada to see how we can start implementing this tool and reaching for resources for families. No, that is happening at the same time. So our guideline usually, as you know, start with the definitions, with the nose, again, definition. We put a very important piece of the prenatal care. Dr. Watson, or we develop like an educational package and a triage letter. So families are going to be aware that we are going to start working on this model, that we need them in the hospital, and if they cannot be present for these 7 days at the beginning in MBU, we need somebody else that can take care of the baby. So, and they can designate that person in that letter. We put the drugs that the babies can withdraw. We establish the process, how the babies can, when the baby needs to be transferred to NICU. And we put a part because our hospitals in Brandon and Thompson's can handle babies, at least with the initial PRN and initial morphine. If they need to escalate, will be transferred to us, but we put that they can do it Sleep Console there until they feel that the resources are not okay. We put a very big piece of breastfeeding and the breastfeeding traffic lights that I found very educational and very good for the eyes to see which medications are contraindicating breastfeeding or not. Clinical features, medications, and weaning protocol. So I know that it's busy, but I can tell you in summary, so the babies are going to stay there, they are going to do eat, sleep, console if something happen, or the baby, for example, cannot eat, or cannot console. They are going to do a team huddle there. They are going to optimize the non-pharmacologic approach and see what happened. All the reassessments are we hope every 24 hours. We don't know yet. The original papers mention that in MBU, some babies can receive the initial PRN morphine to try to break the symptoms. We are in discussion still. There is a bit of concern regarding monitoring. If we are going to use morphine, who is going to provide the morphine there? If we need to observe clinical signs in the baby, we distributed this study that compared babies with NAS that receive morphine or no without any monitor and no significant adverse event, and our loading dose that was 0.1, now we reduced to use as a PRN to 0.05 milligrams per kilo per dose. So it's a microscopic dose that we are going to use. So we need to figure it out that part. If the people from MBU feel comfortable giving the PRN dose, and if it's not, that will be indication for transferring to an ICU, or if the baby received 2 consecutive PRN doses in MBU or 3 in 24 hours, that will be the indication for us to transfer the baby to an ICU. So I mentioned this, and this is the escalation. The escalation protocol, so the initial 24 hours we hope will be PRN doses. If the baby gets, I can summarize it here. If the baby gets 3 PRN doses, we are going to start maintenance. That will be 0.05 milligrams per kilo Q dose per dose Q4, and the PRN, we keep the PRN on top, yeah? So we keep this maintenance, and if the baby needs, we can give the PRN dose, and we reassess in 24 hours. It's not like the Finnegan that we waited 48 hours to have low scores to do any changes. Here is 24 hours. Step 3 will be if the baby continue having or needing these PRN doses more than 3 in 24 hours, we have a personalized approach because some babies maybe receive 3 PRNs, some babies receive 4, and it's a calculation that pharmacy will do for us, that is to know the total dose per day of morphine that the baby got, counting the maintenance and the PRN divided by 6. If we don't have pharmacies or is very straightforward, that level will be 0.08, yeah? Counting 3. And then the step 3 is divided in the algorithm in A, B, C. A is 0.08, B is 0.1, and C is 0.15. So it's the same doses as we used it before. The PRN dose is going to stay the same 0.05 until we increase the maintenance to 0.1 milligrams per kilo per dose. And at that point, we increase the PRN dose to 0.1. At this point, if mom was exposed to any, oh, sorry, it's so blurry. If mom was exposed to any other substance, we can think in adding phenobarb at that point before increasing the morphine. And we are going to start adding clonidine, that is here, when we reach to 0.15 milligrams per kilo per dose as a maintenance dose, no? With the 0.1 milligram per kilo per dose as ERN. Always we need to consult pharmacies, and they are doing rounds with us. We are lucky here. Yeah, and the clonidine going up depends how many PRN doses. If the baby continue having a lot of PRN morphine dose, we will escalate the clonidine as the maximum dose as we use now. We wanted to see if phenobarb was still the first line or the first drug of choice for polysubstance exposure in babies not exposed of opioids, and everybody continue using it, and we know that it's not good for the babies, but we don't have any other any other thing to use. And this is the weaning. So we are going to start weaning first morphine if we don't have any PRNs, no? If the baby is on maintenance, we will, and no PRN for 24 hours, we will start weaning. We can start, we can wean the phenobarb when the maintenance dose of morphine is 0.05. And then we stop completely the maintenance dose of morphine. We kept the PRN, and we can start, if no PRN use, we can start weaning the clonidine. Now, I know that is confusing at the beginning, but then makes sense very easily. And we can discharge home when the baby is off all the medications, when the baby didn't get PRNs for 24 hours. So this is going to be a very change in practice, very big change in practice. We need education, we need training, we need the involvement from pharmacy, no, to provide maybe the oral morphine to. Yeah.
MC.
Mother child unit and San Boniface.
Yeah, they use a different. Then the assignments of the nurses now is something that we need to, the managers, they need to discuss how things are going to work. EPR, that is taking a bit longer, no, to switch, but they are working on that. So for now, we are placing this guideline for review everywhere, and is very well accepted. We have the support from British Columbia and Nova Scotia that are sharing a lot of their experience to try to implement this. These are the 10 components requirements to start working in the hospital and providing it sleep console. And I would like to give a big thanks to Kira, Chloe, and Veronica that were the most important part of this project. Nathan and Chelsea that did the data collection and analysis. Dr. Heather Watson that gave the perspective from mom's management and preparing the mom for this new approach. Christiana and Teresa from pharmacies that help us to develop the escalation and weaning protocols. Calista from St. B, the secretary that she was organizing all the meetings and doing all the minutes. And Lisa Mariel, no, that she was the initial in all of this and did a big change at the beginning. Thank you. Yes.
Yeah, I'm just being pragmatic here.
Yeah.
Looking at the staffing, nursing, in the mother-baby unit, have they actually looked at that
Yeah,
in terms of the load to the nurses? How many patients or patient diets will a nurse take care of when you are doing this? Because obviously it's more work, right?
yes,
And what are the nursing controls saying about this?
in part it's mom's work, no?
But the documentation
Yes.
that will be by the nurse.
But mom is going to have like a diary
Mhm.
where she can put all the observations and all that kind
Does
of
that go in
things.
the chart though? 'Cause
No,
you'll
mom's
need-
no.
You'll need something for the official chart,
Yes,
right? I know it's a short
yes.
scoring tool.
I don't know if somebody from MBU.
Christina is on.
But I just wondered about that.
Yes.
Because it's a practical question.
Yes, yes,
Yeah.
yes. I know that there's a lot of discussion. The managers are
Mhm.
working on that
Yeah,
to try to implement it, but I don't know the details.
yeah, I'm all for
But it's
this
a
program.
concern.
And I've been listening to Eat, Sleep, Console and many conferences that I've attended over the years, and I'm glad we're finally
Yeah.
going to start,
Yeah.
hopefully soon.
Yes.
Can I comment?
Yes.
So I am Ahmed Kordi, I am a fellow from London, Ontario. So we have been implementing
Oh,
this 1 year ago, and there is a market improvement
Oh,
and the
nice.
rate of admission of babies greatly decreased. And I think the most important part here is the involvement of parents initially.
Yeah.
So so this will decrease length of stay because they are already involved from the start.
Yeah.
And you highlight this point, thank you too much. And even we are really using the maintenance of morphine. Even we are in morphine, that's the maximum we have used, as I remember, over this year. So we even not going to the further management. And very important question, as you asked about involvement of mother baby units, because this is also, I think this is a challenge.
Yeah.
The challenge of involvement of the nurses or mother baby unit in this management, because many times I receive the call, oh, this baby is not doing well.
Yeah.
We have to admit, yeah. And then we went there and we assessed our responsibility doing well.
Yeah.
So also, not all the mom will be cooperative.
Yes.
And then we are dealing with certain
Yeah.
category, and this is a challenge. And also involvement of CES early
Yeah.
will help very much
Yeah.
to provide a foster or volunteer. So I think all of this these are the challenges we have met.
Yeah.
And by the time, so I think
Makes sense.
it makes sense. Yeah,
Yeah.
it's very important.
Yeah.
Yeah, which is
That
the complicating thing will be the babies who have birth alerts.
Yeah.
Right.
Okay, so then how's the mom going to cooperate?
Yeah,
and all
but
this?
I
So-
think those moms are going to be approached prenatally by Dr. Watson
Yes,
and their
okay.
team,
That's
and they are going to try to create, okay, if this mom is not going to take care of
Yeah.
this baby,
Yes.
who will be? Is there any family
Yes.
member that
Yes.
would like to step up
Yeah,
or that,
substitute.
or yes, and is willing to stay for these 7 days while the baby is in the hospital. So though I think that first approach is going to give us a lot of, I think, support for this new approach, no?
Yeah.
But,
That's good.
yeah.
One question, it's about like the weaning phases.
Yes.
I want to know, like, after we stop the morphine, do we
Yes.
keep the PRN
Yes.
during the clonidine weaning?
Yes, yes.
Okay, we keep
So
it.
anytime that you are PRN and clonidine, you cannot wean the doses of clonidine very slowly if the baby receive any PRN. So
Okay.
need to be no PRN for you to drop the dose.
Okay.
And remember the other difference that I forgot to put there in my summary is remember that we were changing intervals
Yeah.
before.
Yes.
Now we
It's
leave it
just like
Q4 and
Okay.
winning only the
Okay.
total dose.
So
Exactly.
that is a change.
That is a big
of
change.
practice,
Yeah.
And another question, actually, once Dr. Narvi told me, like, during one of the rounds, that this load of morphine made the difference in our approach in the ICU. from the baby's response. I don't know what was the old practice before, but what I understood from him that we used to give the babies, okay, we want to make change, we did not make load. When we started having a load, there was great response from the scoring of Finnegan. So now just like no more loads, I don't know if it's gonna.
No, but you have your PRN.
Yeah, we have the
Yeah.
clients, but I mean, okay,
Yeah.
that's totally.
It's different setup. So
Yeah.
you use the PRN as a breakthrough of the
Exactly. You
symptoms.
calculate
And
the
if you
symptoms.
need to repeat it many, many
Yeah,
times,
you adjust
baby
it.
will be here and maintenance, no? But
So there is no talks of giving phenobarb while baby's still with mom, or does the baby have to come in with phenobarb? Okay,
Yeah.
Phenobarb comes here.
automatically.
Yeah.
Okay.
And always with.
that is more tricky, no? That is more respiratory depression that the tiny
Longer
dose of.
half-life for phenobarb as well.
Yeah. Yeah. Yeah.
Interesting. Good
Yeah.
work, Fabiana. Can I ask,
Yes,
who did all those calculations for the,
that,
how did you get that data?
Oh.
That's a lot of work.
I know, these
Is
two.
that from EPRs
Nathan.
or?
Yes, from,
Yeah,
I
because
think,
that's,
I don't
wow.
know, oh, I don't have
Data
the
collection, that's the one.
data collection.
I wonder about one thing, actually, the noise effects comparison between St. Boniface and HSC. Is there any
Which
comparison
is
in the
more
length of
noisy?
stay?
Which is more noisy, here or there?
No.
It should be there,
Yeah.
because it's shared bots.
And we do rounds and
Yes.
50
Yeah,
people.
So is the length of stay because it's 16 to 18 days
You know,
because of the
we
pool?
have- We have less babies with an AS over the same week.
Ah,
The population is different. This is
Okay,
so different population.
population's
Yes.
different.
Yeah, one of the ideas that came to my mind about the mini mufflers, if you heard about them, like they use them for those babies who are retired, for the noise protection. I don't know. I don't think it's, I don't know if there's any.
But there was a big difference between the number of admitted babies
Okay.
here and over there.
Yeah.
Baby.
That's great. Yeah, very good, Fabs.
Thank you.
So there are just a
Thank
few more steps and before we can roll it out,
Few
just
more
knowing
steps,
what's the
yeah.
staffing and all that.
Yes, now depends on.
I'm waiting for the next memo.
Yeah.
I wonder how-
I printed this one.
It's little, but we need to do a lot of education.
I was gonna be
think
presented
our
during the
mind
round.
needs to
Yes,
change.
yes.
Is there any talk of having like an NAS, like,
Working group.
not
No.
a working group, but like for the medications and stuff? Will that be on like a standard order sheet so that everyone's gonna order the same thing or the same way?
That's a good point, yeah.
So I think we're
Might be
going to do
another
the
project.
same
Yeah.
as we did before to try to put these algorithms everywhere distributed to all
So that
the
everyone
staff.
knows what they're supposed to order in line.
Hi, I don't know if you can hear me. It's Chloe. Hi, everybody. Fabiana, that was great. Natasha, you bring up a really excellent point, and I think that Fabiana, that in terms of like standing orders and things like that, I think that would be like a great next step conversation as we're preparing for the rollout of the guideline. Yeah, so let's put that on our next agenda because I think that would be great.
Yeah.
I think that'd be a very helpful tool, right? So that it's kind of preset in accordance with the guideline.
Yeah, that will be great. Okay, we will.
Fabiana, I don't know if you can hear me, but I'm supporting Chloe because last time, I mean, your stats showed it that we didn't have, people did not follow the protocol as well as we wanted. And as a nurse, that would be the biggest complaint I heard when we were teaching. So I think
Yeah.
making some standardized sheets actually would be, order sheets would be the way to go, honestly.
Sounds good. Okay, we will work on that. And Chloe, while I was reviewing the graphics, the escalation, so I think I wasn't clear, no? Because we put the formula, no? To put the to calculate the maintenance dose, and we said that maybe we need to put there to a total dose just in case if pharmacy is not around or we have any
Yeah.
issues doing the calculation. So maybe we need to add it, no, in the step 3, A, B, and C.
Yep,
to
yeah.
Point
If you want-
away.
Do you want to pop, yeah, just pop that in a comment on our working document there, and then I can work it into the infographic of the algorithm.
Yeah, Yeah, yeah.
And that would be helpful to have, absolutely.
Yes, and maybe remove that calculation and put it outside and put the total dose, and then put, if we, for example, if baby needs more than 4 or more PRN doses, to refer to do that calculation. But we base those numbers in 3 PRNs, so maybe we can do that
Can do
change.
a little revision. Yeah, absolutely.
Sounds
We're
good.
just we're presenting, Kira and I are presenting with the provincial clinical teams for the women's health and the child health team. So I anticipate we'll have a little bit more feedback and review suggestion from them in the next couple of weeks. So things are coming together nicely.
Yay! 1 year.
We're on a different timeline, right?
I know. Sounds good. Any other questions or suggestions or?
Is the goal
Thanks a lot,
mainstream
Fabiana.
people?
Sorry, Ivan.
No, I was just thanking you. Thanks a lot, Fabiana.
Oh, thank you, Ivan.
Thank you, Faz.
Thank
Good
you.
job.
Good job.
Thank you.